Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jean Sarnowski, and on today's program, we're going to learn a little bit more about what exactly is an ACO. And we're lucky enough to have with us today Libby Merritt, who is a case manager for the Cape Cod Healthcare ACO. So thank you so much for being here. I appreciate it.
Thank you. Glad to be here.
It's good information to get out there because I think there's a lot of headline sort of activity that's unknown and mysterious to most viewers. So, but I'm going to start with, I always like people to know a little bit about you and how long have you been here and what triggered your interest in this field? And
okay. Well, I have been in healthcare for over, I think it's now 22, 23 years. I've worn many hats. I was a CNA, an LPN, an RN. I started out in the skilled nursing facility world, and I spent 13 years in acute rehab at RHCI, which is now Spalding Cape Cod.
Oh yeah.
And I have been with Cape Cod Healthcare for a year and a half.
Very
as
good.
a case manager.
Excellent. So you're very familiar with the Cape Cod community.
Yes, yes.
So you were at the Sandwich facility.
I was at the Sandwich
for
facility,
Spalding.
yep.
Oh yeah, good.
Yeah.
So we'll get right to it because I know there's a lot of information on what exactly is an ACO.
Well, ACO, there are lots of acronyms being thrown around, but ACO stands for an Accountable Care Organization. And Cape Cod Healthcare was granted that status in January of 2013. You have to apply to Medicare, Medicaid, otherwise known as CMS, to you apply and then they grant you the status of an ACO. It basically is saying that we were doing really good work already, that Medicare recognized that we were doing all the right things, we were dotting our I's and crossing our T's, and so we now have the status of ACO. Not everybody gets that.
Not everybody gets it.
No.
So there are a lot out there that are applying that don't make it because of the...
I think more that they just don't apply.
Oh, they already know.
You know, they kind of know that they have to work on their quality, so they're probably holding back applying for it. But it was a feather in our cap just to get the status, so
Yes.
they know we're doing good work already.
All right, good. So once the application is sent and it's granted, what's the next step?
Well, ACOs are, they're aligned with primary care physicians, PCPs. And in the Cape Cod Healthcare ACO, there are approximately 60 primary care physicians.
Wow.
And they are the ones in the ACO. The primary care physicians are the ACO.
Okay, so if we did a little pyramid,
yes,
they're the top of the...
They are the ACO.
Okay.
The patient is attributed to the physician, but it's the physician who's in the ACO, not the patient.
Okay.
You know, so.
That's good.
Yes.
Yes.
So there are certain metrics that the primary care physician need to make, like a standard that CMS has created. 33 metrics, anywhere from cholesterol screening, blood pressures, hemoglobin A1Cs for diabetic patients, lots of metrics that the physician will work with the patient on over the course of a calendar year. So when the patient comes into the primary care physician's office, there are, again, the 33 quality metrics that Medicare is looking that our docs do, you know, what they ask us to do.
So is it every patient gets eyeballed for each one of these?
Yep, again, it's the Medicare population.
Okay,
Medicare, the Medicare population, yes, if they are a Medicare fee-for-service and they are aligned with the PCP here in our ACO, then those 33 metrics should be met.
Oh, great. So if there's a pool of physicians that are the ACO, one of which is my physician, say, am I automatically, and I'm a Medicare patient, am I automatically now in the ACO by default because my physician is?
Yes.
Okay.
You are in because your physician is in. That is kind of the rule.
That's how it works?
Yes.
Do I know this?
Yes. You're notified by the Centers for Medicare and Medicaid via letter. Every Medicare patient who is aligned with a primary care physician who is in an ACO will receive a letter. It's a standard letter put out by CMS. Also, when you walk into a physician's office, you may see a big sign that says, your physician is part of an ACO.
Oh, okay.
You may see it in the hospital, but you will be notified. Sometimes if a patient doesn't get the mail or they missed it, the physician will have just a talk with them saying, I'm part of an ACO. You are now, part of it with me, and we're going to work together as a team to keep you healthy.
Okay. So is it just primary care that are the doctors in the ACO?
Primary care, and there are some primary care doctors who are also specialists. We probably have about 6 or 8 that are PCPs but are also specialists. But that is pretty much just the primary care physician.
Okay. So if I go to my primary care and I'm referred to, an orthopedic to have my knee replaced.
Right.
Are they also by default now part of an ACO?
No, the orthopedic surgeon would not necessarily be in our ACO.
Okay.
No.
All right. So it's really just the primary.
Primary care, and again, those docs who, say, a pulmonologist, but who also
they do both. Okay.
That would be the other instance.
Okay. Now, is it the same as an HMO or an insurance company, or how does?
No, the difference between an ACO and an HMO and managed care and an insurance company, they have very strict stipulations as to what hospital you can go to, which physicians you can see. In an ACO, you have choice. You can go to a different specialist. You can move around from Falmouth to Cape Cod Hospital. If you wanted to go up to Boston, you can. Patients always have choice in an ACO, and that's very different from an HMO.
Okay. And that's good for people to know that about an ACO.
It is good to know, and it works for patients, and some patients don't mind having a stricter guideline, and they may choose to do something else, but for our patients, they do have choice.
Is there still a list of choices that I choose from, as opposed to any old place I feel like going?
No, I mean, we think that it would be great if they stayed within the Cape Cod Healthcare Network, obviously for communication and coordination. But no, I mean, patients can, if they have something that they need to see off Cape, that's absolutely fine. Yep.
Because my brother owns a skilled nursing facility.
Well, that
someplace.
Yeah, we can definitely talk about the skilled nursing facility, the aspect of it.
Okay.
But as far as physicians go, we can definitely, the patient can definitely see who they want to see.
Okay.
Yep.
So then, what's next? How would being in an ACO be good for me? Why is that beneficial for me?
It's good for you because the whole focus of an ACO is better quality care and coordination. And I think the coordination part, the care coordination part, is new. It's kind of been left out. We've all kind of been working in our silos doing really good work, but not all coordinating together. And that's the difference with an ACO. The communication is better and the coordination of care at every level of a patient stay at a hospital or at home or at a skilled nursing facility. Coordination and better quality is a definite benefit.
Okay. So are there members of the Cape Cod Healthcare ACO more than just the doctors? I mean, they refer to other specialists?
Right. I mean, within Cape Cod Healthcare, we have CCPP, which is our preferred physician group, and we have 200 plus doctors.
Okay.
So say, Mary Smith has, Dr. Jones as their PCP, and they need to see a cardiologist.
Okay.
They could absolutely be referred by our ACO doc to a cardiologist here on the Cape, which we have a wonderful group of cardiologists.
Yes, we do.
We're very fortunate.
Yes. Mm-hmm. And other services?
Absolutely. And it goes through all the specialties, as well as we can talk about skilled nursing facilities.
Sure, go ahead. Yeah.
We, again, on Cape Cod are very, very fortunate to have excellent choices for skilled nursing facilities, and it's a huge part of the continuum of care. We have piloted with 6 skilled nursing facilities to just start as we rolled this out. And so we have 6 preferred facilities that we use, and as the clinical nurse liaison, I actually team every patient that is an ACO patient that is at one of those 6 facilities. Every week I go out to my 6 facilities. We talk about every patient, right down to what are they going to do when they get home and who's at home with them.
So who are you talking with then?
I'm talking with the team at the skilled nursing facility. So again, this is the coordination of care.
Okay.
And so we follow them throughout the continuum at that point. But that's also, you know, a huge benefit for being in the ACO.
Yes, yeah. So your role then is to follow me. I'll just use me because it's easier. So I go to my doctor and, well, you had used the word preferred provider. So there must be some other, so there were 6 nursing homes. There were 6. And that was based on?
We vetted all of the skilled nursing facilities, and we worked primarily, and again, I'm the only person doing this, so again, all the facilities are fabulous. And but we picked the 6 that at the time when we went out were taking a more complex patient, a higher acuity patient, because many of our patients in the ACO are quite acute. So we needed facilities that would maybe have a respiratory therapist, and we're already taking some pretty ill patients. So we looked at that and we vetted, and of course we want everybody involved.
Sure.
And hopefully someday we will have all of the wonderful skilled nursing facilities involved with us. But patients do have choice, and they are not sworn to have to go to the 6 preferred facilities that we are working with.
Because my brother owns the place down there.
Absolutely, and that's fine, and we totally understand that. And we will work when that patient is discharged from that skilled nursing facility. If they need follow-up, our telephonic case managers will pick those up. We have 3 telephonic case managers who are...
So what does that mean? Yeah.
They are aligned with the primary care physicians. Okay. So they're busy ladies because there are, 60 PCPs, and so they each are working with about 20 docs. And they are instrumental in that follow-up transition piece when a patient leaves the hospital or they leave a skilled nursing facility, or the doc just thinks that somebody needs to check in on them. They haven't been hospitalized, but a doctor will refer to their case manager saying, you might need to call and just follow up to be sure everything's okay at home, that she has the services or he has the services that they need. So it's really great. So the transitions of care, hospital to home, skilled nursing facility to home, and just the doc saying, I think somebody needs to check on this patient, that's when patients fall through the cracks in the transition. So we're trying to fill all those holes and be sure that everybody has what they need at each level of care.
So almost by definition, the ACO was designed to keep those falling through the cracks from happening.
Absolutely.
Is that right?
Yep. Again, it's really, it's the coordination, everybody coming together, silos coming down, and all of us talking, communicating, saying, Mary Smith needs, a cardiology appointment, or Mary Smith is doing great, but she just needs a homemaker to come in. Can we call Elder Services? It's communication.
So for the viewers that maybe have had an experience previous to being tied in with an ACO physician, they could have gone, and I'm just thinking that people might be watching the show saying, yeah, that would happen to me. I left the hospital, went to maybe home or a skilled nursing facility, and they asked me the same questions, or the doctor didn't even know I had been sent home. Yep. So this picks up on some of those wrinkles that were out there.
Absolutely. When a patient leaves the acute hospital, we look at the day of discharge, and our case managers call the patients if they are high risk, to be sure, if these are patients that didn't go to a skilled nursing facility.
Okay.
So they call and be sure, is the VNA in?
So once they get home, they get a phone call
from the telephonic case managers. And if the case manager, and all of the case managers are RNs, very experienced nurses, great at assessing even over the phone, which is
That's
a
good.
challenge. That can
Yes,
be tough, but
yeah.
they're really, really good. And they can sense if a patient might need some more help, or the patient that says, I don't need the VNA, I'm okay. Our case managers call, and clearly the patient does need the VNA. So then we'll make the referral to the VNA. So they're not just there at home saying, oh, maybe I should have taken the VNA.
Yes.
We'll set that up for them.
So then is the telephonic case manager instrumental in maybe convincing a patient at home that having the VNA come in is a good thing?
Oh, absolutely. They've definitely, I mean, countless stories of, you know, a patient thinks they're okay, and when you're in the hospital and you have 24/7 care, you're feeling strong and you're feeling good, and then they go home and they may be alone, or they may not have any family close by, and then they realize, well, maybe I could use the VNA. So those follow-up phone calls, that transition call is really important. And again, we're trying to keep people healthy in their home and not have them readmitted to the hospital.
Ah, is that part of the design of an ACO?
Absolutely. There are specific illnesses that the Centers for Medicare and Medicaid, CMS, feel should be managed in the community. COPD, CHF, just to name a couple.
So COPD would be breathing issues?
Breathing,
Yeah.
yes. And CHF is heart failure.
Okay.
So many patients have both, and they feel that those could be managed in the community with the PCP and all the help from VNA and case management, keeping that patient in the home, adjusting meds perhaps, being sure a patient follows a diet. That's a lot of, you know, congestive heart failure diet, low sodium. Our case managers are teaching over the phone. They're teaching patients to weigh themselves and to eat low sodium food, read those labels. And in the COPD population, they're making sure patients are using their inhalers when they need to. On a day that the air quality isn't good, stay in, relax, doing a lot of teaching like that over the phone.
Ah, so they'll get more than one call.
Oh, absolutely. Oh,
Yeah.
yes. They'll follow. Our telephonic case managers typically follow a patient for, I would say, about a month. Longer if needed.
So that's
if needed.
after discharge from the hospital?
Yep. Transition call to see how they're doing. But if a patient needs them, they'll stay in, as we say,
Yes.
really on.
Yeah.
They will stay on and follow up and be sure. And again, our communication with the VNA of Cape Cod is wonderful. The handoff is seamless. It's seamless. It really, really is. They tell us when patients are discharging off their service. Our case managers know, then we move right in. Yep, it's great.
So for the patient, for the benefit of the patient, they should feel pretty excited about having their primary care as part of an ACO.
Oh, it's wonderful. To me, it's good medicine, and it's what we've been doing for a long time. But to have it standardized, I think, is really important.
Yeah.
It's really where we need to be.
So viewers that may have had some of these experiences already will probably notice that they're not dialing 911 to run into the ER, especially if maybe they're home alone.
Yeah.
They feel a little panicky, and if it could be something as simple as managing the meds or watch what they eat, some of the other
Again,
tips that you
education is such
Education.
a huge part of it. We're standardizing teaching. That's another part of the ACO. We're standardizing teaching, so Mrs. Smith at Cape Cod Hospital is getting the same information as Mrs. Jones at Falmouth Hospital. At the VNA, we're actually using some teaching tools. Our case managers, the VNA has a wonderful CHF packet that we're utilizing. So the information is going to be the same across the board.
So there's a consistency.
Consistency is so important in educating patients. And the doctors are working on templates for disease states, COPD, CHF, asthma, diabetes. So we're all on the same team, and we're all communicating. I mean, it's only benefits.
Yes, yeah. And then it benefits on the financial side, because I'm sure everyone that's out watching the program has seen all the talk about the rising cost of healthcare, and how much of it is necessary, unnecessary, or what can we do about it.
Yep.
So that readmission into the hospital or people coming back in, that's a big expense.
It is a huge expense, and that's really, we're tasked with keeping them out of the hospital and unnecessarily. If a patient needs to go
Yeah.
back, of course they're going to
Yes,
go back.
yes.
But again, if it's an education issue or just a tweak of a med, that is something that we're working on. And again, all working together, care coordination with the PCPs is going to be instrumental. And change takes time,
Yes.
and it's not going to happen overnight. But you know, some patients will say, you know, I had that test done a week ago, or you know, that repeat testing. Those days hopefully will go by the wards,
Right.
because everyone's going to be talking, and they're going to know that blood level was just done a couple weeks ago.
I know.
And again, when everybody is electronic, when everyone's on a computer, because some physicians and some facilities still are on paper, but everyone's going to be on board very soon, and that data sharing can happen from doctor to doctor, talking about the patient, kind of letting the patient be the center of everything,
Right.
and then we're the team around the patient.
Right. And so some of the new rulings or regulations on being electronic,
Yes,
because some aren't on board, will make it even that much better.
absolutely. I think by the end of 2014.
Is that what it is?
Yep,
Yeah.
everyone needs to
So
be.
physicians, skilled nursing.
Skilled nursing facilities aren't held, they're not at the same standard,
Okay.
but most, if not all, are heading that way, or they're rolling it out slowly. But yeah, everyone's really going to be electronic soon, very
Right.
soon. And then again, that wonderful sharing physician to physician, that information.
Right.
Because many patients think that, you know, Dr. O'Connor
Uh-huh.
knows, you know, that you had that blood work done. Well, he doesn't know unless they're all connected via the computer.
Right.
So that's a phone call or something like that.
So how will they know now? Is that one of the on the checklist for the primary care office now
right
to
now,
communicate?
We're
I mean,
looking
we
to the
hope
pa-
that they do, but because of the ACO status,
Right. The specialists are working together, and within our network, definitely. There's specific discharge paperwork that our primary care physicians get. There is a standard where the specialist will always CC a primary care physician. That means, you know, copy them if
Okay.
they've done any consult or anything like that. But if a patient goes outside of our world here in Cape Cod Healthcare, we really right now rely on the patient to be a good historian and say, oh, when I was in Florida this February, I had some blood work done.
Right.
To let the primary care physician know that.
right?
But hopefully,
So it won't all. It is still good for patients to be keeper of their own information
absolutely,
and
yes.
share that.
Yep.
But now, it makes more sense that
when people are
the
electronic.
caregivers
Yeah.
also communicate. So does that, when you said that about Florida, does that affect, if people are part of an ACO, if their physician is an ACO physician, how does that affect their trip to Florida?
They can absolutely go and have a great time. Lucky.
Yes. Yes.
And yes, their physician is part of it, so they can go to Florida and come back up in April when the weather gets better, and everything will be fine.
That'll be fine.
Yes.
Then are there ACO physicians in Florida that they communicate with, or just?
No,
Okay.
unfortunately, that hasn't happened yet. Maybe sometime that
Well, this
will.
is just the beginning.
Yes.
This is becoming much better, yeah.
But if a patient is in Florida and they have some work done, the Medicare claims will eventually make it to us. That we won't have any results, but we'll just know that, you know, maybe they had an X-ray of their back or they slipped or something. Just an X-ray was done. That's why it's very important for a patient to, when they say share information, it's not sharing results. It's just saying, I got my hip X-ray because I took a fall. You know,
Okay.
but it's not sharing results of any kind of test or blood work.
Okay.
It's just sharing that I had a service done,
Okay.
and that way, the primary care will know.
So on that same note then, that was one of the questions, is my medical information more open to more eyes now because of
No,
the
absolutely
physician
not.
being part of the ACO?
No. HIPAA. I mean, no one who does not need access to the patient record has it. Right now, it's what it always has been. It's the doc, it's the nurse practitioner, it's that healthcare team that would be looking at your information anyway. And only claims would ever come from an outside source. No results at all. So just your healthcare team has access, and only the pertinent access, what they need to see.
Okay. So no different than sort
No
of the
different.
protection that we have today.
Absolutely not.
So if you had to wrap up, why is it good for me as a patient to have my primary care physician be an ACO physician?
Well, I think the coordination of care is instrumental. The doctors working with specialists, the communication is increased. The transition, again, from home to hospital, hospital to skilled nursing facility to home. Hopefully there'll no longer be those gaps in that. And that's when we find that patients do come back to the hospital. So that's what we're trying to eliminate. And again, we've always done great work. Again, we were granted the status, but we're going to keep dotting our I's and crossing our T's and doing what's best for the patient. And those 33 metrics, CMS is going to be looking at that.
Oh, yeah.
And we're going to do it.
That's good.
Yes.
That's good. We have about a minute left, if you can believe it. So I just want to be sure, is there anything that you'd like people to know that we haven't already kind of touched on?
I think one thing that no fees change.
No cost to the patient.
No fees change and no benefits change. It is straight Medicare fee-for-service like it always has been. You still have choice, but you're going to have a lot of helpful hands along the way. I think
so you might get a few more phone calls, which will be a good thing because you'll know people are out there caring, right? Yeah.
Yes. Yep.
Yeah. Well, Libby, thank you so much.
Thank
That's
you for
great
having
information.
me.
I'm sure everybody understands a little bit better about what an ACO is and what it means to them to be part of it.
Great.
Just quick, do you know how many people are in, how many patients are in the ACO?
About 20,000 are in there.
Wow.
Yep.
And that's on the Cape Cod
That's
ACO?
our 65 or 60 PCPs and their 20,000 patients.
Great.
And 4 case managers.
Wow. You're very busy.
It's all good.
It's all good.
Yes.
All right, thanks again.
Thank
I
you.
appreciate it. And I'm Jean Sardowski wishing you good health and good health care.